We'll now move on to our next presentation, which is by Dr. Joshua Denny, who is the Chief Executive Officer of the All of Us Research Program. Dr. Denny will share with the Council an update on the All of Us Research Program and Advisory Panel, which is a working group of the Council of Councils. Dr. Denny, the microphone is yours.
Thank you so much, Dr. Eisinger. It is a pleasure to come before you. Last time was a couple years ago, and report on where we are with the All of Us Research Program. And at the end, I'll go over a little bit of where we are in terms of our advisory panel as well, which, as you say, is a working group of the Council of Councils. The mission of the All of Us Research Program is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. And we really think about this starting with nurturing partnerships with participants, at least 1 million diverse participants across the United States. And then we want to deliver that biomedical data set that our participants so graciously and freely give to us and share that into as many researchers' hands in a secure and trustworthy manner as we can, and then catalyzing an ecosystem of community researchers and funders with the vision of all of us becoming an indispensable part of health research in the future. We launched nationally in May of 2018, and I'm excited to say that we just crossed 700,000 participants that have consented to joining the program and 500,000 biosamples. 500,000 participants have donated biosamples from that data set. And people do participate across the United States, including all 50 states and most U.S. territories. Not all of those locations have had the ability to, for instance, collect biosamples when we started, but during COVID, we developed technologies to allow people to really donate and participate in more ways from all parts of the country. We've always been focused on diversity. There are many forms of diversity, and race and ethnicity is one of them. You can see we're about 50% non-Hispanic white, and really focused on recruiting and focused engagement on diverse populations by race and ethnicity, but also the vast other ways in which disparities exist in other populations that are underrepresented by biomedical research. And you can see those listed on the bottom right there, looking at income, disability, sexual gender minorities, educational attainment, and more. And in this fashion, in both of these categories, we have a lot more information than the high-level information provided here. Most people that select Asian, for instance, specify more than 90%, another more exacting specification of their ethnicity. The kinds of data we collect, regardless of where you come from in this largely digital-first program, is similar, whether you join through an academic medical center, an FQHC, or other way of joining across the country. So it starts with a video consent process, consent to get electronic health records, participant surveys, which are ongoing processes with new surveys released approximately yearly. We collect some physical measures, biosamples, and allow participants to donate and share wearable technologies like Fitbits and other devices that they may have into the resource, as well as doing pilots whereby we are actually giving devices to people as well. And we just went through another round of getting out an additional 20,000 devices to people that were largely underrepresented by biomedical research. A key value has been returning value to participants as well. What we found from our participants, both in the beginning and then later, was genetic information was some of the most important kinds of information that people would seek to return. Most of the interest was around health-related genetic information, but we return other kinds of information as well, and you can see some of those examples there. These are some screenshots of the kinds of things we return. So the first thing we started with was genetic ancestry and traits, which are non-health related. You can see what some of those look like. And we've had over 130,000 people view their genetic ancestry or traits. And then at the end of 2022, we started returning health-related genetic information. First is hereditary disease risk, 59 genes that are actionable. If someone has a pathogenic or likely pathogenic variant in these genes, there's something they can do to intervene on the health risk. And we know the vast majority of people will not know of this before getting the genetic testing. And overall, that's about 2 to 3% of our population that will have one of those. And then medicine or DNA or pharmacogenomics, we look at 7 genes which affect a variety of medications. And both of these conditions, where you can see we're approaching 57,000 and 60,000 individuals that have viewed these reports. On these reports, what we know is that we have genetic counselors to help support in the process, the return of information, and we have also found that it is something that a vast majority of people understand well. We're supporting it. They understand. They're appreciative of the information they're returning. We're returning about 5,000 participants a week, letting them know if they want their information generated, and then we return that. So we've been able to scale this up, but of course it started in the end of 2022, so we still have a lot of catch up to do. Researcher data access is multi-tiered. It starts with pulling together data across the country and our number of different data providers through common interfaces. Those data are harmonized. We apply consistent privacy methodology across them. All obvious personally identifiable information is removed. We have public tier of information that anyone can explore through the data browser, and then individual data row-level access is accessible for research studies through a researcher workbench. And then we also are building ancillary studies on top of this. And this involves things like recontact, use of biospecimen for particular studies. And that's mostly something that we are really seeking to build out. We're really at our infancies of that. As of April, we have released what is currently the largest set of broadly available genome sequences for research. So you can see the counts of participants that have provided various sorts of information in this latest data release. And we're releasing about one data set a year now at this point. So it's over 400,000 with survey responses, 245,000 with genome sequences. We've also introduced long read sequences in this data set, about 1,000 people with long read sequences. We have about 15,000 at this point with Fitbit records. And when you look at this data set of the size of 245,000 whole genomes, that gives us, we've currently observed variation in about 1 billion locations of the genome. And, notably with our data set, which is about 50% diverse by genetic ancestry, that's really allowed us to see a lot of variation that may be novel. And about 2/3 of that billion sets of variants are not in the most common current releases of Nomad, and notably 113 million genetic variants that we've observed occur in 3 or more of our participants and are not in Nomad. So I think that really speaks to some of the diversity of the population, the size of the population that we've been able to recruit. A number of researchers are using the resource. We've more than doubled the number of researchers that are using it within 2023 already, with approaching 7,000 researchers, nearly 7,000 active projects. The number of publications are really increasing. There's 220 or more already, but it looks like about more than 100 of those are within 2023. So those are really kind of increasing more recently and accelerating. And we've really been trying to seek to reach out to organizations broadly. So nearing 600 organizations, we've intentionally reached out to HBCUs and Hispanic serving institutions and tried to create resources such as this picture here, funding Baylor in this instance to really engage and help bring on what would be underrepresented researchers to help them access and learn how to use the resource, processes where we pair inexperienced researchers with experienced researchers and create ambassadors, especially to those who would be typically underrepresented in the research community. And you can see our numbers there, over 20% by race and ethnicity, which would be a race or ethnicity other than white or Asian in terms of the biomedical workforce. So we've really been seeking to do this. We want to increase these numbers from where they are. We think it's an important aspect of our program. These are some of the pictures of different papers that have been published recently. We're seeing people doing a lot of work in non-genomic spaces. We're seeing work in genomic spaces, rare disease, common disease. We've seen some of our highest impact papers have been associating Fitbit data with clinical outcomes and changes in exercise and activity levels, for instance, during COVID, and what diseases have been associated or how it could affect other components as well. And you can see some pharmacogenetic studies that are starting to be pursued, or at least looking at drug effect analyses as well. We have been deliberately working across the NIH for funding opportunities. This is just an example of some of these. We work with most of the institutes and centers on an R03 and R21 program that has really broad support across institute centers and offices. And we hope to be funding 21 applications from this. And we had a very robust application process through that. And then we have a couple, as you can see, active funding opportunities on the right there. Some of those are in partnership with other ICs, and there's a QR code to read more about those. In addition, we have launched our own rolling engagement opportunity, which focuses on engagement and enrollment and communications. And notably, I'll highlight that that is available for all these kinds of exercises, but especially we're looking forward to pediatric enrollment, pediatric engagement, and also made a call out for people that would engage tribal communities and tribal research communities as part of that, as we actively work proactively in a consultation process with our tribal leaders. I want to give one example to walk through as an end of what it looks like to use the resource. And so I used a personal example here. My first genome-wide association study that I did at Vanderbilt as part of the NIH's eMERGE network that discovered something new was using primary autoimmune hypothyroidism in 2011. And we worked across the 5 sites of the eMERGE network at the time and discovered some genetic factors here on chromosome 9, which is representing a thyroid transcription factor. It took us about 2.5 years to do this, and 40 people working across the various sites. And we came up with this algorithm on the top right here, which was validated at different sites using billing codes, all ICD-9 at the time. ICD-10 had not been released in the US at the time. Lab results, CPT codes, a number of different components, and then analyzed the data, and you can see the results. And so I gave a challenge to a new postbac in my NIH research lab that I accessing the data in the same kind of way that any researcher does. He applied to the resource. He does not have a formal genetics background. He has actually just started medical school at this point after taking a year off to do research. And so he was able to build this algorithm using our web-based interface, really no coding needed for that. He's able to get his ICD-9 and 10 codes automatically pulled in from searching for and picking the right phenotypes. Same with medications against different names of those medications, brand and generic. And then here is his GWAS results. And you can see markedly better results than what was done in 2011, which is, not unexpected. What's really exciting is this is a truly trans ancestry GWAS. And so you see results. If you look at the different genetic ancestries on the right, you see different populations showing up there. And notably, from my challenge to him to when he produced his first results of this, took him about 6 weeks. And he worked largely on his own, figuring out how to do these analyses using the tutorials we have online. So we really hope what we're trying to do is really democratize the ability to do this, put the power in the hands of more people, the ability to point and click and get 1,000 CPUs if you need to do an analysis, and really make it available to a broad community. So I wanted to reference our advisory panel, which, as Dr. Eisinger said, is a working group of the Council of Councils. This is our current advisory panel, and we are looking. Scout has been a member and representative of the Council of Councils, and we're looking to add another member, and we're in the process there to continue the collaboration. And you can just see it's a great group representing a number of different backgrounds of everything from community advocates and participant advocates to pediatrics and tribal leaders and HBCUs and a number of other components, including machine learning and large language models as part of that as well. So in the future, we're looking in 2024 to expand to more than 400,000 genome sequences in our next curated data release to researchers, expanding the long-read sequencing we're doing as well. We should have pretty significant increases in digital health technology from wearables that we've been distributing proactively, which I think will increase that data set significantly. And we have new surveys that are coming. We just launched one in mental health and well-being, which has a value component to our participants, as well as really assessing an important aspect that we all know where we are in this country and world with mental health. And it's an important aspect to bring in here. And some of these actually have time point references that can be looked back during COVID as well. So with that, we have also launched an ancillary study. We have a couple that have launched, but this year we launched Nutrition for Precision Health, which is a collaboration with 18 different institute centers and offices across the NIH. That is enrolling now, and all participants in Nutrition for Precision Health are part of All of Us. The goal is 10,000 participants in the first module of that, and then there's some deeper modules that we'll get into randomized trials of different diets and even some domiciled feeding studies as part of that. So we're excited for that to be kicking off and actively enrolling as it is now within the All of Us infrastructure. So with that, I'll thank you all for where we are, and I'm happy to take some questions.
Yeah, just a couple of questions. First of all, I had a blast participating this summer in the All of Us Symposium. I think it's impressive how much diversity there was in the room, as you said, far beyond what a slide can show in terms of beliefs and just ideology, and yet all unified toward a single vision. So you guys have really been phenomenal at showing how that can happen. With that, though, I have two questions. First, the I know that there are Native Americans that are in the data, and I also know that there was an issue that Dr. Malin wrote about that related to sort of, privacy protection. Can you say a little bit about that? I noticed that the pie chart does not show, it shows only Native, Pacific Islanders. So that's my first question. The second question is that the numbers didn't quite add up to me. If you have 700,000 participants, I didn't see any one category of data that was 700,000. I think the largest was surveys. Can you just explain how we get to how they can be in it, but actually, not have at least one category where everybody's put data income?
Thank you. I'm happy to address both. And Kevin gave our keynote at our last in-person meeting, in which we really talked about our key goal for this year, which was developing our pediatrics program. And so that's been job one for 2023. And Kevin, as a pediatrician and actually my former boss, did a wonderful job, and I really appreciate you being there doing that. So first, on the American Indian Alaska Native question, we individuals who self-identify as AIN have enrolled within the program. With our consultation process with tribal leaders, we have currently not released their data in the CDR. So that is why they're not showing up in the pie chart, and that is why they're not part of the current data release. And we actually have a consultation later this month where we'll formally address the next steps on that. And we have really purposely thought a lot about this and reached back out to those who self-identified with specific materials as part of this consultation process, educating them about where we are in the process. And we've learned a lot from them just in terms of the engagement efforts. And so we look forward to expanding that components. We've already added elements to our resource access board, which reviews these kinds of proposals and monitors the resource use with AIN representation. We have that in our IRB and looking to expand it. And so there's a lot of ways in which we're really thoughtfully engaging and looking forward to moving forward with AIN data being included as our participants, really have wanted that to happen. The next thing would be the counts. So the difference between the counts that you see on the front page and total is that's what is enrolled, and that's like up to, maybe not up to the minute, but at least certainly up to the day of where we stand. And then the other numbers that I represent are the data that are currently released in the data in the researcher workbench. So those are the data that have been curated, amalgamated across all the different folks, and they all have cutoff dates for what the data sets are. And so, for instance, we've generated already way more genetic sequences than 245,000 that have been jointly called and made available. So all those numbers are more closer in terms of what people provided, are much, of course, closer to the totals that you see.
Thank you.
Thank you, Dr. Johnson. Dr. Krugman, you're next.
Hi, thanks very much for this. I have my annual or semi-annual question about the inclusion of information on the participants of their experiences with child maltreatment, physical, sexual abuse, neglect. Last time I asked, it was being looked at. I'm just interested to know what the decision was about asking and including this information.
Yes, thank you for the question. I'm happy to give you a different answer this time, actually. So the mental health and well-being questionnaire that we just launched this summer actually includes some questions on adverse childhood experiences and other kinds of elements related to that. And that survey is available to participants. We've had over 70,000 completed already, and we'd be happy to share it offline if you'd like to see a copy of what's in those questionnaires.
Thank you, Dr. Krugman. Dr. Lloyd, I believe you have a question, and we'll try and come back to the others.
Yeah, Dr. Denny, Josh, I know you've demonstrated why you're the right guy to lead this job, and they made a great decision when they selected you. So congratulations on the progress. The program as initially, envisioned was to enroll 1 million plus participants. You're on your way, but I wondered if you could give us an impression of where you're at in terms of your annual accession goals. Are you starting to flatten out? Are you finding some barriers that you're not growing as fast as you have in the past? And if you got some ideas how you might finally achieve that 1 million, perhaps plus participant goal?
Thank you so much for the question and the kind comments at the beginning. You know, we had a huge barrier in 2020. Enrollment basically went to zero, and because we were more than 99% in person for collection of biospecimens when COVID hit. And so 2020, 2021 were very lean years as we built out ways of reaching people virtually. I would say that we basically have lost, you know, we're about maybe, because of COVID, maybe 2 years of a delta from where we would have been, not as a formal analysis, but, you know, approximate. Where we are now is still in some ways recovering. I think this is the first year that we've seen numbers that more closely approach where we were prior to COVID, but it's different. It is harder now in a lot of ways than it was before. Some of the narratives and discussion points around trust, around governmental science, some of those things are a little different than they were before. And so our engagement partners are really key to us having some of those messages and communications with our participants. And not all geographies have been affected the same as we went through COVID and coming out. So I would say that we're approaching numbers, but they are still lower than where we were pre-COVID. One of the other things, though, that we come out with now that we didn't have before, as I alluded to in the presentation, is really the ability to reach anyone anywhere. We're so much better at that now than we used to be, and I'm really glad of that. So it gives us some opportunities to do some things we weren't able to do before and reach people in ways that we couldn't reach before. So we continue to look to expand this as we, you know, kind of move forward. And I think that I hope that next year, I expect next year actually to be able to build on where we are this year in terms of numbers and also in terms of our ability to reach geographies and, importantly, add children into the mix.
Thank you, Dr. Lloyd. Dr. Gandhi, I believe, is left temporarily, but I will just read her comment, which is that just an amazing effort between this and AI could really see precision medicine being realized. And for the final question, Dr. Robinson-Beal, please.
Thank you, Josh. I just want you to know that I've been a participant of all of us for the past 2 years, so I'm one of those little dots in there. My question is this: has there been any effort or thought about lining up or aligning with large systems? Like, for example, United Healthcare, we have 59 million people who are members. You know, people get motivated when they have an issue, a diagnosis. There's certain events that would help drive people to want to join all of us. I'm just wondering, has there been any thought about that in terms of lining up with health systems, particularly insurers, where this might help boost your numbers?
A great question, Rhonda, and I would love to actually continue that conversation if you're interested. We have done some work with some insurers out there, and some have sent notifications to their participants. We have also worked with groups like CVS to send out mailers or emails to folks as well, and that has been a pretty significant source of enrollment. And that gets back to us being able to reach anyone, anywhere. Some of those enrollment technologies, you know, without those, it wouldn't make sense to reach out to people through a mailing list, but we certainly can now. Most of our enrollment has come through medical centers, especially pre-COVID, and now you know, we're starting to see a pretty significant percentage of people that aren't. So I think that is a great opportunity that is not completely tapped, certainly, as you point out, and some opportunities to do kind of disease-triggered, maybe focused enrollment as well. We can make some relevance there, which we haven't done to date. So thank you.
Thank you, Dr. Robinson-Beal, and thank you, Dr. Denny, for joining us today and taking the time to meet with the Council and to provide this overview of the All of Us initiative.